and I think only the speakers are here. Hope we'll have more audience sooner. Uh, we'll have Dr. Harsh Kumar, please. He'll be talking to us on the essential skills for glaucoma diagnosis.
Thank you, Satyan, for having me here. And it's not moving. Okay, I think it's not going forward. Yeah, okay. So friends, I think it's very, very important that we do learn some of the very basic things, and making a rapport with the patient, a thorough disc examination, art of recording the pressure, and understanding gonioscopy, to my mind, are the four basic skills that you must learn in order to really detect what glaucoma is. And obviously the most important thing is the optic disc. Basically because many of the patients who come to us may initially have normal intraocular pressure, perimetry may not be accessible to so much of our population. So the heart of glaucoma diagnosis is a disc evaluation. So please buy your own 90Ds, please buy your own gonioscope. That is the most important thing. You are looking at the optic nerve, and the most important thing you want to do is to check the optic nerve with a magnification or with a stereoscopic view. So obviously something which is available to all of us is of direct ophthalmoscope. The problem is that it gives you a very magnified view, and it is not having stereopsis. So the best indeed is either a 90D or 78D lens, no touch. The only thing is the pupil may be a limiting factor, and there is an inverted real image, so you really have to change it in your mind. You are looking at the rim first, and then you are looking at the cup rim, so that you have the neuroretinal rim, which is the most critical thing which we are looking for. And the next thing that you want to really understand is the retinal nerve fiber layer. And these are the earliest changes that you can get. You can get a no. Is there a pointer? Is there a pointer, sir? Mouse में नहीं वो चल रहा. Okay, yeah, please put off the light because we can't see. So you can see there's an early notch, and there are some nerve fiber changes over there. And this is another interesting case. Normal field, normal disc, everything was normal. The pressures are a little on the higher side, but the CCT was high, so we let it go for some time, and then the next time then we saw it, there was an early wedge defect. So even the notch has not appeared, the field is normal, but the first thing that you may get is a structural change, and that is why very, very important to assess the disc first. Everything else can come later, and this is something which in your hands. Can you put off the lights or not? You're trying, okay. So, and then when we did the OCT, we found that there were pre-perimetric changes. Again, you can look at the periperiphery atrophy, but more important is the retinal hemorrhages. If you have a disc hemorrhage, you are pretty much sure that later a notch will develop and there will be a wedge defect there, and they also signify that there may be progression. Very important to remember the isn't rule, that is the inferior margin normally is the thickest, and inferior margin is the thickest, followed by the superior, followed by the nasal, and this is how the damage gets increased. So you really, if you keep it in your mind that inferior margin should be of the neuroretinal rim should be the thickest, you can catch it on pretty fast. And the moment you see that, oh, this has become less, you should catch on that something is not normal with the disc. We have to investigate for glaucoma. And you have to check for the color. The size is also very, very important. We know that the size varies between 1.4 to 2 millimeters. We get so many patients, we are investigating for large cups, but what is actually happening is that they are just large discs having large cups. So be careful. How do you measure the size? The small aperture of Welch-Schellen is equivalent to the size of the disc. But the other way is that you can obviously see the vertical diameter by having 90D lens focus with 1.3 magnification, and over here you can vary the size of the slit beam. multiply it by 1.3 if you have a 90D, and you get the size of the disc. And very, very important, because so many other times what happens is that people think that the cup is large, but they are only physiological cups. So like here you see that, oh, there is an asymmetry, the cup is larger, but what is actually happening is that this disc is larger. The field is normal, but you see that the total overall area of the left disc was much, much larger, and that is why the cup was larger. This small girl went around getting all investigations done because of the large cup, but what was actually happening was that the father was having similar cups. So you have to be very, very sure that you are dealing with physiological cups. So you be very careful what you are dealing with. Asymmetry is important, and if there is a vascular anomaly that you have to look for, that there is a bearing of the circumlinear vessels, that means the tissue over here is being lost. Same with the overpass cupping. And splinter hemorrhage we are already talked about. It can tell you that there is a progression. And if there is a pale disc, be careful. Either it's a neurological, even in angle closure you can get these pale discs. And so be alert, get a pituitary scan done. You may be able to save patient's life over there. And always map it out. Always check for size. Neuroretinal rim isn't tuned. Look for vascular changes, look for asymmetry, and please document serially. Again, the second important thing is taking pressures, and this is an art, and it's not only purely a science. Obviously, to us, Goldman is still the best. I'm not going into the details, but you should know what are the plus and the minus things over there. Get the right Myers, which will be like this and pulsating, so that you know that you are reading the pressure correctly, and 40 Myers should be avoided. And yes, the disadvantages are there, but I think still it is one of the best that we can get. Don't depend on NCT, because it will give you false pressures many a time, so just take it as a screening tool. And indentation tonometer, I know that we don't like it, but if you have it, please learn how to use it freely. See that the plunger is going in nicely up and down, and the way it is to be sterilized. Obviously there are too many disadvantages, and please check it. Learning gonioscopy is an art, very important. 50% of our patients will be angle closure, so be very careful and learn how to do a gonioscopy. Please use only 1 mirror, 2 mirror, or a 4 mirror. Do not use a 3 mirror at all, because I think that's a strict no-no for us. And be very careful, learn the art of indentation so that you can know what is synechial closure and what is just an appositional closure. And that's what we said, please do not use 3 mirror for that. Learn what is, how to disinfect that, and learn what are the angles that you keep seeing with every patient, and you'll know. So just write, do not write grades, just write what you are seeing in all the quadrants. So you can see we are seeing the scleral spur here, we are seeing the ciliary body band, and that way it doesn't confuse us. And learn how to differentiate between open angle, angle closure, and synechiae, along with, and how to differentiate with goniosynechiae and angle recession. And I think if you have learned that art, that will be the that will be the basic skills that you will be requiring. Thank you very much.
Briefly discuss and then carry on with the topic? Or? Oh, sure. Thank you. So the topic on complementary diagnostic neurology will also be covered by Dr. Pradeep, since Gauri she could not be able to come here.
Good morning, friends. Thanks, Dr. Krishnadas and Satyen, for giving me this opportunity. I would not only discuss what Dr. Harsh said, but I would be talking on behalf of Dr. Gauri, and then probably I would be discussing my own topic on behalf of Tanuj. So I have got 17 minutes. Harsh has taught us the clinical skill to diagnose the glaucoma. Yes, all of us knows that the diagnosis of glaucoma is very important, very critical, because we have seen lots of false positive and false negative in glaucoma. The patient who are having glaucoma are not diagnosed as a glaucoma for a very long time, and the patients who are not having glaucoma were diagnosed to have a glaucoma. So the correct measuring of the IOP, the good thorough clinical evaluation of the optic nerve, and correct measuring of the intraocular pressure is important. But all of us knows that glaucoma is not only 24 hours disease, but it's a lifetime disease. So it is highly mandatory to know the progression of disease and to know that you are treating the patients, whether your treatment is effective, because whatsoever damage glaucoma causes is always irreversible. So obviously the clinical skill is important, but the science is also equally important, because the science would tell you that whether your patient is progressing and whether your treatment is effective or not. As I said just now, that we have lots of false positive and false negative, and obviously yes, if you have a good clinical skill, then at least you would be able to diagnose glaucoma appropriately. And for that, you have to measure IOP, you have to see the optic nerve head and do a thorough clinical evaluation of the retinal nerve fiber layer, do the good clinical assessment of the angle, and the standard automated perimetry is a functional test, which is highly essential and critical to diagnose the glaucoma. And you have to have the holistic approach. Just a single things out of all these cannot diagnose the glaucoma. Just on the basis of intraocular pressure, you cannot say that the patient has a glaucoma. Just on a basis of the clinical examination of the optic nerve head and the RNFL, you cannot say, because many of the patient would have a tilted disc, oblique disc, large disc, small disc, so many a times it becomes difficult, and just on the basis of the optic nerve head and the RNFL, you cannot always say that yes, this patient has a glaucoma and this patient does not have a glaucoma. Angle assessment is very critical, but you know, it has a objectivity, and I may say that this angle is open, and somebody else may say that no, it is a positional closure, and so on and so forth. So obviously for all these things, the complementary diagnostic tools are important. The functional test, I don't know, I would not say that it's a complementary, but it's an essential test for diagnosing the glaucoma and assessing the progression of glaucoma. So clinically what we say that, you know, as I said, that it's a holistic approach, and the standard definition of glaucoma is that there should be a clinical changes in the optic nerve head and the RNFL, and the correlating changes on the visual field, that is a standard automated perimetry. If your patient has this, then irrespective of intraocular pressure, you may say that yes, this patient has a glaucoma, or this patient does not have a glaucoma. The perimetry has lots of problem. All of us knows that there are performance-based errors. There are many patients who are not able to perform the perimetry well. Obviously, there is a short-term fluctuation and a long-term fluctuation, and there are several factors which affect the perimetry, that includes the media opacity and the pupil size and so on and so forth. But as I said earlier, that glaucoma is not just a diagnosis of glaucoma, but basically it is the assessment of the progression as well. And the perimetry is a very, very critical test for assessing the progression. You can see over here that over a period of time, how this patient has progressed. So obviously, if you want to prevent the needless blindness because of the glaucoma, then you have to intervene aggressively, or depending upon the perimetry result, you have to take a call that how you have to intervene. Like this patient, over a period of time, I thought that this patient has progressed, but when he underwent the cataract surgery, the fields has improved. So the perimetry would not only tell you that whether the patient is progressing or not, but would tell you again that it's really a pathological progression, or the progression is because of something else. Once the cataract was removed, again the visual field has become to the normal level. And see the rate of progression in this patient. If I would not intervene aggressively for this patient, then this patient would go blind in next 3 to 5 years. So all these are very, very critical. So after the diagnosis, the appropriate diagnosis of glaucoma, you have to assess the progression. You have to see whether the therapy you have started on the patient is effective or not, and what is the rate of progression, so that you can take a call. In very advanced glaucoma, it is very, very difficult to assess the progression, and again the perimetry is a good tool. You can do the serial 10-2 analysis, and you can assess the progression. That is what the glaucoma continuum, you have been seeing the slides, and I have been seeing the slide for almost more than 10 years, and Professor Weinreib has showed very categorically that the glaucoma progresses and we are not able to pick up just by doing the perimetry alone, because when the defect appears on the perimetry, many of the patients have already lost almost 30 to 40% of the ganglion cells. So we have to pick up the glaucoma at very early stage, and for that you need to have the complementary diagnostic tool at your disposal. See this patient. So see this patient, you can see that this patient has a splinter defect over here and there is a disc hemorrhage. Obviously, and when we did the standard automated perimetry, and this was absolutely normal, but the swab was done and you can see that there was an early inferior arcuate scotoma which was correlating well with the disc changes. So obviously this is one of the complementary technology which was helpful, and the FDT was same, but these days we are not doing the swab and the FDT for varieties of reasons. The swab takes very long time and the patients are not able to do well. So, and of late we are more dependent on the objective, not the objective test, not the subjective test, the objective assessment of the structural defect. And for the objective assessment of the structural defect, we have a technology at our disposal, that's an imaging technology, by which we can assess the macular area, the optic nerve head, and the RNFL in the arcuate area. So all those areas which are affected in glaucoma can be assessed by the imaging technology. You can see that, how the papillomacular bundle has gone in this patient, which was picked up by the OCT and was not able to pick up by the perimetry. You can see that this was the patient where all the times the perimetry was normal, but this patient has progressed on the OCT, and subsequently we have seen that this patient has shown some changes on the standard automated perimetry as well. That is how you can pick up the glaucoma progression on the OCT based examination, and obviously the OCT is able to pick up the glaucoma progression early as compared to the progression you can assess on the perimetry. And now there are newer tools available. They are probably maybe a more complementary for diagnosis of glaucoma and assessment of its progression. One of that is the NGOCT. You can see that this is a normal disc, and you can see that the vessel density over the optic nerve head, and in the patients having a glaucoma, you can see that the vessel density, the capillary density on the optic nerve head. So all these tools may complement your diagnosis of glaucoma and may be helpful in assessing the progression of glaucoma. Similarly, the anterior segment OCT is also pretty helpful, because again, it's an objective test. There is no subjectivity involved as what is there in the gonioscopy, and other advantage is that it's a non-contact technology, and as I said that there is no objectivity is involved. And similarly, like you have a glaucoma continuum for the open angle glaucoma suggested by Professor Weinreb, you can have a glaucoma continuum for the angle closure glaucoma as well. There are various risk factors involved for the development of the angle closure glaucoma, and then subsequently the patient has an intermittent angle closure, and then going to the chronic angle closure, and then eventually goes into the blindness, because it's a very fast progressive disease. So these factors which are responsible for causing the angle closure glaucoma can be best picked up by the complementary technology like the anterior segment OCT, the UBM, and the pentacam. What are those important risk factors which otherwise we cannot pick up by doing the simple gonioscopy, or the obviously the short axial length you can pick up by just doing the biometry, the shallow anterior central depth of the anterior chamber, the decreased AC volume, the thick and more anteriorly positioned lens, and thick and voluminous iris. All these can be picked up by the anterior segment OCT. You can see that, once the pupil goes into scotopic condition, the patient who are predisposed for the angle closure glaucoma, the volume of the iris increases. So this is what we have documented, the volume of the iris increases in the scotopic condition. That is one of the risk factor for development of the angle closure glaucoma. Another important risk factor is the lens vault. If the lens vault is very steep, then these patients are likely to develop the angle closure glaucoma, and that can be picked up by doing the anterior segment OCT. Obviously, you can assess the bleb morphology by ASOCT, and as I said earlier, that the anterior chamber volume is very important, and with the pentacam, you can measure the anterior chamber volume so that you would know that these patients may develop the angle closure glaucoma or may be at the risk of developing the angle closure glaucoma or not. The UBM is another technology which is very helpful, where some of the information you cannot gather by doing the ASOCT, you can gather by doing the UBM, particularly the condition like the Plateau iris syndrome, because the penetration of the UBM is little more posterior as compared to the anterior segment OCT. So all these hallmark feature which suggest the Plateau iris configuration of the syndrome can be picked up by doing the UBM. You can pick up the iridociliary cyst by doing the UBM. So in nutshell, the complementary technology, yes, we say that it's not easily accessible to most of the people in our country, but this complementary technology do help us in not only diagnosing the glaucoma, but also picking up the progression of glaucoma, and they have not yet become very standard, but probably it may be the future for diagnosis of glaucoma and picking up the progression of glaucoma. Thank you very much for your patience hearing.
Pradeep, thank you for having agreed to give that lecture at a very short notice, 4 days if I'm right. Thank you very much, we really appreciate that. Would you like to discuss in place of Tanuj, or is there anything more you would like to say regarding investigations or
I think we can have some
questions?
Or,
You need to.
Or somebody else would like to discuss something?
Or shall we go ahead and reserve the questions at the end of the session if we have time? We need to clear the hall by 8:55.
Thank you. Thank you.
So the next session, we are not having Dr. Sati Devi here. We will have Dr. Murli speak on diagnosing glaucoma, which is an interpretation of numbers. Ganesh, I'm sorry, Ganesh. The light is not sufficient, and we are also pressed by your pick, so I'm sorry about it. Okay.
Thank you, sir. I'd like to thank GSI and AIOS for providing me this opportunity to speak to you here on diagnosing glaucoma as an interpretation of numbers. As we have all seen, Dr. Harsh Kumar has also already mentioned that skill set is very important, and Pradeep Vyas has also mentioned that you should use auxiliary testing for coming to a conclusion. But ultimately, it's all about numbers. It's supposed to be a debate, but Dr. Sati Devi could not be here, so I'll try to see if I can, bring about how. I think now I have 10 minutes now, so how we can have a skill set versus numbers game in glaucoma. So historically, the glaucoma has always relied heavily on intraocular pressure measurement. But we should also understand that glaucoma is multifactorials. And multifactorial, there's a wide variation from patient to patient in the level of the intraocular pressure that is truly indicative of the disease. So like Dr. Harsh Kumar has mentioned, the first presentation of the patient, usually the intraocular pressure will be low. Sorry. So multiple object tools are required, and to monitor the trends and fluctuations, and to make sense of the subjective and objective data, and to determine the urgency of treatment and the best modality for treatment. So you have to identify the pattern and trends in visual function and reconcile the condition of the nerve structure to help identify the early stages, the disease in the early stages. So skills versus numbers, you would always know that you can measure the pressure even digitally, but ultimately now we depend on Goldman applanation, because that's where you get a number which can be easily communicated between practitioners and even to the patient. And how many of us know the machine on the left? Or how many of us know it? And who are the people who really, sort of were not using it now? So that's the Goldman perimeter. So why did we jump onto the automated perimeter? Because now it's ultimately a numbers game. So you need more objective testing, but of course you must also remember the automated perimeters also have kinetic perimetry system in them. So it helps us to test the patient with low vision with kinetic perimetry also. And the new equation is pachymetry. Without central corneal thickness, I don't think we'll be able to come to a conclusion as to what level the risk of the patient is in. And these are all the studies which also mention that the OATS particularly, that the central corneal thickness is very important. And as already been mentioned, gonioscopy is also in the future, it may be replaced, we don't know, because you get such high definition images and it's very useful. But ultimately, gonioscopy has to be done for a comprehensive clinical examination. But at the same time, again, if you want to communicate to somebody, then again you want to talk about numbers and how much is the angle opening distance so as to get a perspective. CD ratio we have been measuring ever since Armali has described it. And we also know that planimetry can be done. All the people who work on advanced imaging techniques on optic nerve head have at least one paper on planimetry. Even the Chennai glaucoma study, the initial paper was on planimetry. So that's also a skill set which is required, but ultimately now it's being replaced by imaging, because you want more objectivity, you want how much is the thickness of the neuroretinal rim and the RNFL, how much is deviating, and you also get a red-free photograph in the machine. So again, other issues which you want to assess, again they come in numbers only, they don't come with skill sets. So how you use it, how you interpret it is very important. Auxiliary testing all is about numbers only. So of course you need the skill to check the intraocular pressure, you need the skill to do a Doppler, but at the same time, interpretation is what matters. And all the trials are about numbers, whether to treat or not, how early to treat, whether medication or surgery first, or how low the IOP should be, what to do with when medications don't respond, and what is the best glaucoma surgery. So ultimately, skill set will be affected over a period of time because of age, busy schedule, busy clinic, medication, either the patient or the physician related factors, instrument downtime, administrative reasons, change in technology. Thank you for your patient listening.
Thank you, Ganesh. More on this later when Murli tries to summarize. We will go for Dr. Shanta's topic on medical management.
Good morning. I'd like to thank you all for having given me this opportunity to be here and to talk to you. So the key goals of treatment are to preserve vision as well as maintain the quality of the life of the patient. And the only significant risk factor which we can deal with now is intraocular pressure. To what extent should intraocular pressure be lowered? That is our first decision. And we have to decide on our target intraocular pressure, which is usually a range. And this is based on baseline intraocular pressure, baseline disc and field changes, the rate of progression of field loss from the time of diagnosis, and if there are any non-pressure risk factors. The baseline intraocular pressure can be obtained from the patient's old records if the patient is already on treatment. If the treatment naive patient, you can get a office DVT or a Diurnal DVT if you have the logistics for it. Baseline disc photography or at least a detailed disc drawing, and if possible, optic nerve head imaging needs to be done. Visual fields have to be done for any glaucoma patient. At least 2 reliable fields exams have to be obtained, and determine the rate of change by obtaining at least 3 visual fields for the first 2 years. To what extent should the IOP be lowered? This will depend on the stage of the glaucoma, and the various clinical trials have told us that what is the minimum IOP lowering that is required for these patients. For ocular hypertension, around 20%. For early to moderate glaucoma, 25 to 35% from baseline. And for advanced glaucoma, 35 to 48%, sometimes even 50%. These numbers are just rough guidelines. The treatment has to be individualized to each patient ultimately. You establish a target range rather than a number and constantly reset the target to each individual depending on the therapeutic response and the rate of progression on medication. So how aggressive should your treatment be? This will depend on the rate of loss, as I had told you. So this is the age-related loss, which is normal. This is a patient who's slowly progressing and is unlikely to develop significant functional impairment. But these two patients who are fairly young to start with are rapidly progressing, so the treatment has to be much more aggressive in these people. So your target will depend on these factors. If it's a high target IOP can be set, if it's an early glaucoma, short life expectancy, high untreated IOP with no other risk factors, and the progression is slow. Whereas it has to be a low target IOP if it's an advanced glaucoma with long life expectancy. The treatment, untreated IOP is low to start with if there are additional risk factors like reduced ocular perfusion and if the rate of progression is fast. So which drug would you choose? That would depend on drug-related factors and patient-related factors as seen here. Drug efficacy, you have to decide in terms of the drop in IOP, in terms of reduction in diurnal variation produced by that drug and the duration of the effect. And this meta-analysis gives you a rough guide of the peak and trough changes in intraocular pressure by the various medications, so you know what kind of lowering IOP you will get with these. And these give a range from 15 to 23%, timolol moderately with 26%, and the PG analogs give the best reduction in intraocular pressure. So the treatment algorithm start with establishing a baseline, start with monotherapy, choose the drug according to the condition being treated. Remember the systemic medication that the patient is on and the disorder so that you avoid drugs which may be contraindicated. The target IOP required. Use the simplest regimen possible with the least adverse effects and remember the contraindications. So this is a case scenario where this patient presented at a fairly young age with a family history of glaucoma. The intraocular pressure was around 25 and 26. CCT was slightly on the higher side for our population. And the right eye disc was normal, but the left eye had a nerve fiber layer defect. So this patient required treatment. His fields were normal, but 25% drop initially would have been sufficient. So we can decide between these two drugs. So we started on one eye with the latanoprost, and you can see that there's a significant drop in IOP in the treated eye. So the same treatment was given in both eyes. This was a second patient who again had similar pressures, but with thinner CCTs, open angles. These were fairly moderately advanced disc and field changes. So initially we started on timolol. There was at least 25% drop in intraocular pressure. Over a follow-up period, there was slight progression. The pressure started creeping up, so it was changed to latanoprost. The pressure came down again. However, it continued to progress, so it was changed to a combination of timolol and latanoprost. The IOPs were fairly stable over the next 3 years. However, he continued to progress, so ultimately one eye had to give a combination therapy and continue the latanoprost, following which the pressures were stable. But what is important to note here is that you have to change the baseline when the patient progresses. So once you change the baseline visual fields, the progression doesn't appear to be so rapid. So the points illustrated in this treatment algorithm is that first substitute, then add, then reset the target when progression occurs. Use combination therapy wherever possible to reduce the amount of preservative reaching the eye and to improve the adherence rates. Follow up with the visual fields regularly and redefine the baseline of the visual field at appropriate times. Systemic conditions, you have to remember that the patient may be on systemic beta blockers, so topical beta blockers may not be very effective. And other systemic interactions have to be kept in mind since most patients are elderly on a long list of systemic medications. Is the mechanism of action a consideration? You have to use drugs which are complementary in action to get the maximum effect. What is maximum medical treatment? This is the minimum number and concentration of drugs which give the maximum drop in IOP. The maximum is usually 3 drugs. If you use a 4th drug, you have to make sure that at least an additional 15 to 20% drop is achieved, and this is seen in only 40 to 60% of patients. So ultimately, the patient will require a laser treatment or a surgery. So the treatment is tailored to each patient depending on the age, extent of damage, the effect on the quality of the patient's life, and the costs incurred. Treatment is constantly assessed and changed when a progression of disease is detected. Once maximum treatment is in use, the next step has to be laser or surgery, a decision which is again tailored to the individual. Thank you.
Thank you, Dr. Shanta. Murli, brief comments? I believe your comments are only for this topic. Okay, we'll have some time to discuss because Ganesh went uncontested. So we'd like to have some discussion on that.
somebody has to contest Ganesh. He can't go away without being debated. So obviously, I think you cannot use only numbers as far as glaucoma diagnosis is concerned. You need to have a skill set as well. I think the typical example would be gonioscopy. So you cannot have ASOCT telling you is narrow angle or open angle. You can't have gonioscopy telling you is there a PAS or not. You can't have gonioscopy telling you is it pigment dispersion or is it pigment blotches are there and so on. So obviously we are still in the age in which gonioscopy cannot be replaced. We need gonioscopy for sure. And it's a very key important factor for glaucoma diagnosis. Similarly with the disc evaluation. I think you can't have OCTs telling you that the disc is glaucomatous or disc is normal and so on. You need to have an estimate of the size. You need to have a clinician's judgment. I think even after many, many decades of glaucoma practice, many of us still err on the side of glaucoma diagnosis by looking at the disc. Somebody says it is glaucoma, somebody says it's not glaucoma, somebody says it's suspect. So I think a skill set is definitely useful as far as the key elements like gonioscopy and disc evaluation are concerned. There's no doubt that you need numbers, there's no doubt that you need machines, there's no doubt that you need technology, but you have to complement each. I think the complementary talk on complementary therapy was fantastic. So I think you need to mix both. You need to have a clinician's judgment as well as the skill and technology required for glaucoma diagnosis and management. I think management was very nicely spoken by Dr. Shant. I don't think I have much to add to the medical treatment of glaucoma. I think the key factor seems to be now that the pharma companies are aggressively marketing drugs left and right, all kinds of combinations and drugs are available. So I think the key factors would be that to start a rational method of medical management, start off with a single drug, evaluate the therapy, then add or substitute depending on the type of patient you are dealing with, and then the newer combinations are available. I think very often we see in our so-called glaucoma clinics, patients being started off on combination therapy straight away. Started off on irrational combinations like dorzolamide, timolol, along with the timolol, prostaglandin, all kinds of irrational combinations. So we need to know the drug which is being used. We need to know the composition of each combination available. The so-called fixed drug combinations are available in so many names and numbers. So I think the names are deceptive. We need to look at the ingredients, what actually the bottle contains. So that's very important as far as practice is concerned. I think we also now have timolol-free combinations which are now available. I think many companies are making that. I think we need to know that so-called maximum therapy could now mean 4 drugs in patients who are not offered surgery or any other method of treatment. A fixed combination with two fixed combinations with 4 drugs could probably be the maximum medical therapy and so on. Thank you. I thank GSI for the opportunity to be here.
Thank you, Murali. Yes, madam.
Just to answer Ganesh's numbers, I think the skill is in looking at a patient when he walks into your OPD and saying, this patient already seems to have some allergy. I won't look at these particular drugs. I won't look at brimonidine. I won't look at dorzolamide. And the ability to put all the examination techniques, whether you're doing it clinically or whether you're using the complementary techniques, putting them together to come to a diagnosis and saying the probability, because all the numbers will only look so nice, but they have to be put together into a probability that the patient actually has ocular hypertension or the patient has early open angle glaucoma or very early PSC. So it's the ability to put all the numbers or the examinations together, which is the skill that is involved in actually managing the patient properly. And as Dr. Shanta said that, the ideal would be you start one medication, start the second and whatever. But again, the skill comes in saying this patient has a pressure of 40. I can start 2 medications, or I can start 2 medications and maybe Diamox for a couple of days and then take the Diamox off and see whether the 2 medications are working. So it can't be that there is an algorithm and you're just going to follow the algorithm one after the other. It depends entirely on the patient that you see. So I think numbers are good. The objective measures we have are very good, but it's the ability to put it together for a individual patient that is their skill.
So do find that compliance and adherence also cannot be monitored with just numbers alone. Patients may apparently look like well-controlled pressures, but their fields will look like it's worsening. You don't really know why it's worsening until you know the patient's history. You talk and you find out from the patient. Is he using the medication? Is he coming for the regular follow-up and so on? Adherence is something which only a clinician can judge.
Thank you. In short, if we put as even interpretation of numbers requires a skill, then skills gain an upper hand. You had a comment, sir? Somebody? Yeah, sorry, I'll come back to you, Shanta.
Sorry, excuse me. What about ocular tomography in diagnosis and management of glaucoma? This is questions for all speakers.
Tomography or? Tonography. The role of tonography. You have a response for that, madam? Please. We'll have the last comment from Dr. Shanta.
I think we used to do ocular tonography earlier to determine the outflow facility. But I think these days it's not really being used. The ocular tonography machines are not available. So the only way to do it is to put a Schiot's tonometer and wait for 4 minutes and take the 2 readings at the baseline and 4 minutes later.
Yeah.
So it is a possibility, but it's not of great clinical significance.
The only comment I had was that with reference to numbers, from the clinical trials, the data which has come, and especially from the AGIS trial where people decided that 12 millimeters is the holy grail for glaucoma patients. So for example, I had a patient with a baseline IOP of 50 millimeters. He had to undergo a trabeculectomy. There was a good filtering blood. The pressure came down to 20. And the visual fields were stable. But the local ophthalmologist had decided that the pressure should come down to 10. Put him on maximum medications, and then the bleb flattened out within 4 to 6 months. So this concept of very aggressive treatment and trying to achieve a very low target IOP, regardless of what the other information regarding the patient is, I think that is something that we need to keep in mind. So that's where the numbers game can get us into trouble.
I'll completely go with you, madam. Actually, many of the patients, when we visit Africa, that's what was happening. Though the pressures were around 18, 19, all the patients are on medications thinking that the target pressures has to be somewhere below 13. So all the blebs had gone in for a scar formation because of the multiple medications. With not much of a delay, we'll go to the next topic. Devan, you wanted to add something, I'm sorry. Just add whatever, you have some time.
The concern about numbers is that in medicine, normal is very difficult to define because of the wide range. And numbers would, so what could be normal for one, in terms of numbers, may not be normal for another person. All instruments where they're using numbers predefine normal. So you could be normal, not fit into the database, and be classified as disease. And that's where we all need to be very careful.
There is a minor change in topic. Dr. Ramkrishn's topic will be on opportunistic screening for glaucoma. And I think this is quite appropriate for general practitioners as well. So we have exactly about 10 to 11 minutes, I think. And this has to be shared with Dr. Chitra's talk also. So 5 minutes. I'm sorry to put pressure on that.
Problem. Thank you, Krishnadas, and thank you, AIOS, for the opportunity. And of course, glaucoma is early diagnosis is very important to reduce blindness. And of course, all of you know about the glaucoma in 2020 worldwide. What is the figure, and also prevalence of glaucoma in India. And of course, in developed nation, the bilateral blind is almost more than 20% are bilateral blind, and of course, there are so many undetected glaucoma in the country. This is one of the important things we have to keep in mind, because most of the prevalence study in glaucoma shows that more than even our own comprehensive survey, it's nearly about only 93% of the patients are unaware of that they are having glaucoma. Only 7% are diagnosed to have glaucoma. And also the burden of glaucoma in India, of course, more than 20% of world glaucoma is in India. India will become a second overall in number, and of course 6 million more than the Chinese, and Asian will make up more than 80% of the angle closure glaucoma. This is also one of the studies by George. And the reality, what is the reality today, is a poor access to the screening, and of course the patient typically present at late stage because of the asymptomatic nature of the disease. And of course, the primary and secondary centers do not effectively screen for glaucoma routinely as a comprehensive examination. And another important thing what we discuss now is the poor adherence to medication and follow-up. This is the reality nowadays. The percentages of glaucoma examination, most of the other ophthalmologists, they do not practice comprehensive examination, because intraocular pressure measurement, this examination, gonioscopy are not routinely taught in residency program, and also number of glaucoma specialists are very less, and most general ophthalmologists, they treat glaucoma without knowing the basics of glaucoma. The infrastructure, of course, is very much lacking, and the present status is a cost, and another thing is another important thing about the medications. So how to create an access and the screening and diagnosis of glaucoma? Because it's a multiple approach. It's not like other diseases where you can screen the whole population. Wherever the patient is coming for the medical this thing, we have to screen them, especially hospital-based approach. And family screening is again another important thing. Whoever is having glaucoma, we have to call all the family members for the glaucoma evaluation. And the community outreach. Most of the hospitals in our country are now doing this type of community outreach. So wherever they go, they have to make attempt to diagnose glaucoma in the community. And of course, we and some of the other hospitals, they have vision centers. This is one of the best place to screen glaucoma in a rural area. And of course, special glaucoma screening camps and World Glaucoma Awareness Week and other things. And of course, in the hospital base, it's very, very important to measure intraocular pressure for all patients above the age of 40. That's routinely what we are doing. We do in-seat in general clinics, and any suspected cases should be referred to any intraocular pressure more than 21 or a fundus changes or family glaucoma will be referred to glaucoma clinic, and a comprehensive examination including everything just discussed and everything, and also then of course family screening is another important. Nearly about, there's another thing is what we are doing routinely. We have a separate counselor for the family screening. Whoever is diagnosed to have glaucoma, or the whole family members are given a card and ask them to come for the glaucoma screening, and it's one of the best program what we have started about a few years ago. Then of course in community outreach, not only cataract is the main focus, we have to screen for glaucoma, at least we have to do intraocular. We have started doing Perkins in all our community outreach, and also in most of the cases, most of the camps, we started doing fundoscopy with fundus photo, handheld fundus camera. And of course in its detection rate is 1.03% in the camps. And also vision center is again another way to go about the glaucoma screening. It covers about 50,000 people, and we have a trained technician. All vision centers are equipped with fundus camera, and we this is what we are doing in all these centers. And the fundus images will be transferred to the base hospital, and the base hospital will see the fundus, and according to this one, and also intraocular pressure, we will advise the patient for either to come for follow-up for treatment or come for periodical follow-up. And also this current status of our glaucoma screening in the camp, and of course opportunity screening in rural India is a role of vision centers. We have done a study in one of our vision centers, and we are able to do diagnose most of the glaucomas by this way. So the results are very much encouraging, and we are able to diagnose most of the glaucoma in the vision center by this method of fundus camera installing in this one. So to conclusion, teleophthalmology also is one of the important thing where we can install in most of the places, which will help us to diagnose glaucoma in its early stages. And also during World Glaucoma Week and other special occasions, we can make other awareness activities in the radio and the TV, newspapers, and doing so many screening camps for glaucoma. And and what needs to be in place to deal with the glaucoma in the community is first we have to make awareness in the community, because it's very much lacking in even medical fraternity, and also the screening wherever possible we have to screen them for glaucoma. And of course diagnosis, not only diagnosis, we have to start treatment, and the follow-up is very, very important, because most of the patients, even in the big centers, even we have 5 years for Satyan has done a study, only there is about 7% of the patients are coming follow-up for the end of the 5 years. So each of these components needs to be in place for effective glaucoma
sir, we'll
diagnosis
summarize.
and screening. Thank you very much.
I would like to Chitra to just briefly tell us about when systemic evaluation is indicated. It would be nice if it is without the slides also. We can finish it quickly.
No, doctor, you have to hear me out.
No, we
You
need
know,
to
it's
have.
like asking me to do a
we need
mad
to
rush
respect
to the
the
winning
next
post.
session.
I'm going
No?
to catch a train, but I'm going to
Anyway,
talk.
thank you. Thank you.
I don't think people will come here before 9. So, when should I get a systemic evaluation in my glaucoma patients? I'm sure most of us know what I'm going to talk on, but the enormity of the disease and the way the statistics tell us that how it's going to be increasing to 2020 and 2040 tells us that there is a lot more about this disease management and progression which needs to be looked into. But probably these are the rounded areas are the 3 main areas where we need to concentrate: the normal tension glaucoma, or those suspicious looking disc, and the secondary glaucomas and the childhood glaucomas. So again, NTG often becomes a diagnosis of exclusion, but it's most important to know that we're not missing out some major risk to health in these situations. Nowadays, there's a lot of information about obstructive sleep apnea being associated with NTG. There are papers talking about association. There are other papers who are not very corroborative on this information, but definitely the repetitive closure of the upper airway during sleep and leads on to hypoxia, hypoxemia, hypercapnia, and increased vascular resistance. And this leads to an abnormal blood flow regulation in the optic nerve, and naturally the whole cascade of events starts. So these were some of the articles which have the questionnaires which came up. What was the extent of sleep loss and the tiredness during working hours, and the associated systemic hypertension, and host of questions which were asked, which helped us to score what was the extent of the obstructive sleep apnea disease, and a positive risk factor if found in that questionnaire. If that was associated with obesity and snoring, it definitely indicated that this patient went in for an overnight polysomnography, and we diagnosed the disease and treat it so that we can allay the progression of the disease. Again, this was another study where about 180 patients of glaucoma were assessed for the systemic disorders and the medications taken, and the association of these with the progression of the disease was minutely looked into, and it was found that though there were many patients where the hypotension became aggravated because of the combination of the beta blockers, or the cardio-inhibitory effects of the diseases got aggravated, or a hypoglycemia got masked, and so much more, which made us wary that we really need to look into the systemic drugs which are being taken when a patient has a glaucoma disease. In other words, it also brought to light that the arterial hypertension and hypotension are equally linked to glaucoma. So then the diastolic perfusion pressure needed to be looked, and it came to an understanding that a critical value about 50 to 70 millimeter mercury should be acceptable, below which you should be wary of glaucoma disease progression. So then we also need to remember that systemic blood pressure has a diurnal variation, and there is a trough between 2 o'clock to 4 o'clock, and there are 2/3 of our population who are dippers. And then what is most important? Why do we need to look into all these things? Because an exaggerated nocturnal hypotension is going to cause ischemia of the optic nerve head, and naturally it is going to lead to a progression of a glaucoma in a well-controlled intraocular pressure eye. And then if you do not get to the crux of the systemic drugs which are associated and deal with them, you have missed the game. Again, so that indicates that we need to monitor a 24-hour blood pressure and adjust the BP drugs accordingly so that you avoid an excessive nocturnal dipping. It is as simple as this, which could be looked into. Again, there are these young patients who have a glaucomatous looking disc and all these findings which are associated. And then sometimes you wonder whether you put them through a field test, but when you do, you have this characteristic vertical, respecting the vertical meridian, and when you go on to an MRI, you notice an occipital infarct, and it just drives you into a different direction of management. Again, this was another patient with a pallor and the large optic disc, and then he had a characteristic field defect, and it was a tuberculoma, which needed a different management. Again, going on to the secondary glaucomas, these are the 4 essential categories which have to be looked into when we think there could be a systemic association.
Again, an elevated episcleral venous pressure, any number of lists of venous obstruction, AV malformation, anomalies and idiopathic condition could be ruled out by a simple history, a good physical examination, and of course, when in doubt, a neuroimaging would give additive information. As simple as just looking at these tortuous blood vessels and blood in the Schenck's canal would clinch you, and then you find the fields is normal, the OCT is normal, but the physical examination keeps telling you there's proptosis, and when you go on to evaluation and you treat this patient, you are able to give them a quality of life, or rather prevent them from endangering their life. Again, neovascular glaucoma could be associated with the systemic vascular diseases, as has been listed, ocular vascular diseases, which are so commonly seen in diabetics and hypertensives. It could be associated with inflammations and retinal detachment. So many common issues which are there in our day-to-day practice. Sometimes it could be something which you just cannot clinch a reason for neovascularization. There's an asymmetric diabetic retinopathy, and then you suspect ocular ischemia, and then you go on to doing a Doppler study, and then you are able to locate the cause. So then, the next area where we need to be concerned is a uveitis glaucoma, wherein the same algorithm of management of uveitis coexists with the management of glaucoma. There's only one condition in uveitis where you need not go hunting, as in a glaucomatocyclitic crisis. Again, with intraocular tumors, when you have an asymmetric unilateral disease without an obvious cause, it definitely mandates that we do a good ocular examination, look into the history, and go deeper and delve into something grave which is lurking underneath. Childhood glaucomas, we all know, coexist with systemic anomalies, which needs to be looked into. A paucity of time, I'm not going into it, but maybe like in one you need to do a renal ultrasound, in one you need to look into skeletal disorders, and in one you need to be very careful when you're doing a surgery. In a Sturge-Weber's, we need to do a neuroimaging which further clinches you onto the diagnosis. But before I end my talk, what is most important is you're stuck in a pathway where you don't know whether you're going to do a lifelong treatment or you're going to observe these eyes, whether you look at the eye as a whole ganglion system, support system, and manage it forward. Do you have to look at the healthcare system, the amount of information, is it needed? Is something suspicious going to come with it? Is it a burnt out disease like a pigmentary dispersion glaucoma or a steroid-induced glaucoma? But then it makes sense that we need to take the patient somewhere ahead from where he is and do our best towards our patients. Thank you.
Thank you, Dr. Chitra, for keeping up the promise, and I would like to be grateful for all the faculty and of course the participants, in spite of a compelling presence of Saurav outside the hall. Thank you very much. We need to give space for the next session. Thank you.